Welcome to AETCM, the emergency medicine channel. Today let us discuss about management of urinary tract infection. Urinary tract infection is one of the most common infectious disease which can come to emergency room. It can even come to OPDs also, but in emergency room they come with severe sepsis, cystitis, hypotension, shock and all. So basically the definition of urinary tract infection is the organism should be there in the urine, and the number of midstream urine organism in culture should be more than 10 to the power of 5 organism per ml. So if that is there, then you can confirm the patient is having significant urinary tract infection. Sometimes you can get urinary tract infection, but when we culture, you don't get a sufficient number to meet the criteria of this more than 10 to the power of 5 organism per ml or 1 lakh organism per ml. The problem is sometimes the patient may be partially treated. Then even if you do a culture, you may not get this much organism. But without antibiotic, if we are not getting this much organism in the urine, then it is not a significant UTI. So UTI can be subdivided into lower tract infection, that is urethritis, cystitis, upper tract infection, acute pyelonephritis and prostatitis, intrarenal perinephric abscess. So urinary tract infection divided into either lower tract infection or upper tract infection. Most commonly lower tract infection come to OPDs, but whereas the upper tract infection like pyelonephritis, intrarenal, perirenal, perinephric abscess, all these problems come to emergency room or ICUs. UTIs are very common in female patients, but it is very rare in male patients. That is because of the anatomical organization of the female reproductive organs or urinary tract in the pelvis. Whereas in adult, that is very important. In adult, if you are getting a urinary tract infection, there has to be a reason for that. But in female, without any major structural abnormality itself, patient can have urinary tract infection. Especially in pregnancy, you can get an increase in number of urinary tract infection. Whereas in males, normally urinary tract infection is not at all common. But if you are getting urinary tract infection in a male patient, it can be associated with a structural deformity or diabetes or trauma or sexually contracted diseases. In that structural sexually contracted diseases, in that structural deformities like strictures, towns, prostatomegaly, malignancy, trauma, especially after catheterization, all these things are very common in male patients. And prostatitis and prostatomegaly induced urinary tract infection is very common after 50 years. So in a female patient, urinary tract infection can be a simple urinary tract infection, but in male urinary tract infection, routinely it is not at all common, and if it is associated with a structural deformity, this is sometimes called as complicated UTI, complicated urinary tract infection. So any urinary tract infection associated with any complication in the tract, or patient is having an immunocompromised status like diabetes, this urinary tract infection, this type of tract infections are called as complicated UTI. Whereas without any structural deformity or without any diabetes, the urinary tract infection is a simple urinary tract infection. You can see in the difference between male and female urinary tract. The structural difference you can see is female urethra is a short urethra, so contamination from external organs are very common in female patients. So urinary tract infection in female patients are not complicated. Most of the time they are not complicated, but in males they are always complicated. Now in children, some adults, there is a condition which is called as vesico-urethral reflux. It's a predisposition for urinary infection. It is defined as reflux of urine from the bladder into the ureter and then to the renal pelvis. So you can see here there are 5 grades different classifications of vesicoureteral reflux. These refluxes sometimes can produce structural deformity in the ureter and sometimes a problem in the kidney, and it can lead to permanent scarring, urinary tract infection, all those things. It is very common in children. This type of urinary tract infections are very common in children, especially in male child. If you are seeing urinary tract infection, this has to be evaluated thoroughly. Now, when we talk about organism which produces urinary tract infection, most of the organisms which produces urinary tract infection are gram-negative organism, especially E. coli. 75% of the UTI is due to E. coli, then Protease, Klebsiella, Enterobacter, Pseudomonas. Some gram-positive cocci also can be there, Streptococcal, Cephalococcus, Staph aureus. Sexually transmitted UTIs are very common in sexually active males and female. Chlamydia, Neisseria. Neisseria is the organism which can produce gonorrhea. Herpes simplex virus. Fungal urinary tract infection, very common in diabetic patients. Mycobacterium tuberculosis. So TB is one of the conditions in our country which can produce urinary tract infection. Whenever there is a culture negative urinary tract infection or recurrent urinary tract infection without any positivity in the urine culture, you have to always suspect TB urinary tract infection, especially in diabetic patients. Now, when we discuss about clinical features, we all know that any infection will produce fever, and urinary tract infection you can get severe chills, rigors, severe vomiting, low back pain, lower abdominal pain, flank pains, hematuria. Some patients can have hematuria, some patients may not have hematuria. Then renal angle tenderness is seen in many patients. Other than that, patient can have pelvic pain, urgency, urinary emergency, like that. They can have symptoms of urinary tract infection. The most common symptom will be dysuria. So patient will always complaining about pain during micturition and incomplete evacuation. Immediately after urination, again patient will feel that irritation in the urethra and will go for urination, and it will be patient will be having spasmodic pain. Patient can have hematuria, back pain can be there. Fever with chills is a classical finding for urinary tract infection. Now, if you see the spectrum of urinary tract infection, there are varying different presentation for urinary tract infection. Sometimes it can be asymptomatic. It is classically seen in diabetic patients. Acute simple cystitis and acute UTI with presumed to be confined to the bladder only. Symptomatic acute urethritis, this will be highly painful. Patient will have severe pain during micturition. Acute pyelonephritis, patient can have high degree fever, chills, rigors, loin pain, and sometimes patient can have hypotension, shock. Prostatitis, it is common in males after 50 years. Septicemia, this is one of the common cause for septicemia in emergency room, and many patients can have diabetes. Diabetes patients present with septicemia due to UTI, elderly individual, diabetes patients, other immunocompromised status. Sterile pyuria is patient can have pus in the urine, but there is no culture positivity. This can be due to various conditions. It can be due to a partially treated urinary tract infection, fungal urinary tract infection, viral urinary tract infection, tubercular urinary tract infection. Sometimes in elderly female, there are a lot of pus cells. They are not actual pus cells, they are only WBCs. So shedding of cells are very common in elderly individual. So that itself can produce pyuria. It looks like pus in the urine, but it is not actual pus. So we have to take a detailed history, clinical examination. All these things are important. Now, pyelonephritis means infection in the kidney. So it's a type of urinary tract infection, but it occurs in the upper urinary tract, and patient can have fever, flank pain, tenderness, and other features of urinary tract infection. So classical finding will be renal angle tenderness and guarding. Now, pyelonephritis is a bacterial infection of parenchyma of collecting system, and we have already seen the features of pyelonephritis. Both acute and chronic pyelonephritis can be seen in many patients. Chronic pyelonephritis, we have to be very careful because we need to evaluate thoroughly to rule out conditions like vesicoureteral reflux and bladder abnormalities. Whatever it is, the investigation has to be done in pyelonephritis in detail, because we may have to consider other causes for pyelonephritis like immunocompromised status, like diabetes or malignancies. Renal malignancies can be there sometimes, or any other infections with multifocal infections can be there. So detailed evaluation has to be done for pyelonephritis. Especially you can go for ultrasound and CT, contrast enhanced CT. So one of the problem which we face during pyelonephritis is contrast is sometimes difficult because the elevated creatinine contrast may not be possible sometimes. But ultrasound itself can pick up pyelonephritis. Most of the time ultrasound will pick up pyelonephritis. Depending on the clinical features, we can give antibiotics, and once you treat the infection, you can see the creatinine is becoming normal, then you can go for contrast enhanced CT scan. Now, perinephric abscess is another problem, renal or perinephric or perirenal abscess. This can also be a part of urinary tract infection. There are two types of perinephric abscess. One is one type of abscess can extend from the kidneys to surrounding tissue, but sometimes it can be hematogenous spreading. Hematogenous spreading, most of the time they are gram-positive infection, but an infection coming inside from the kidney can be mostly gram-negative organism. Whatever it is, blood culture is more important than urine culture here. Now, when we are treating a lot of patients who is having diabetes, immunocompromised status, prostatic enlargement, other structural deformity, many times we will have to put the patient on urinary catheter. You can see many patients who is on urinary catheter can develop urinary tract infection. Sometimes they are symptomatic, sometimes they are asymptomatic. But we have to always see symptoms like what symptoms means. Patient can have fever, chills, rigor, hypertension, shock. Sometimes they are asymptomatic. The problem here is many patients who are immunocompromised, they may not have symptoms. Like patient who is having diabetes, patient is having chronic liver disease, their immune status is very low and immune capacity is very low. Whatever infection occurs, the immune reaction will not occur, so they may not have clinical findings like fever, chills, rigors, hypertension, shock. All those things may not be there, but slowly the infection will mount up and ultimately patient will go to multi-organ dysfunction and failure. So it's our duty to find out the infection in a patient who is having clinically immunocompromised, and if there is an immunocompromisation, even if the patient is not symptomatic, if we are finding a urinary tract infection, it is better to treat the patient. Whether the symptoms are there or not, we have to treat the patient. If the patient is immunocompetent, like there is no problem for immunity, then sometimes we can defer the treatment for asymptomatic bacteriuria. So many patients on catheter can have urinary tract infection. Depending on the symptom, depending on the immune status, we have to treat the patient. Organisms are mostly E. coli, Enterobacteria, Pseudomonas, Enterococci, Staphylococci, fungi, all these things. So look at the creatinine value, look at the blood culture. If patient is going for a sepsis, then better to treat the patient. If the patient is having immunocompromised status, then better to treat the patient, even if even if there is no clinical features of urinary tract infection. Now, when we talk about urinary tract infection, we have to think about the investigation part of urinary tract infection. So normally we ask for a urine routine test. Normally we don't find any pus cells in the urine, especially in a male urine. But in a female urine, you can see up to 5 pus cells in the high power field. So males, we don't see up to 3 can be taken as normal, but in female patient up to 5 can be taken as normal. In male patient, you should never see an RBC in the urine, but in female patient up to 5 to 8 are considered as normal. Whenever we take a urine sample, it is always recommended to take the urine sample as a midstream urine sample. That is very important. Midstream urine sample is most important, and any urinary tract infection can be associated with elevated WBC in the urine. You can see pus cells or WBCs are very high in a urinary tract infection. Without urinary tract infection, if pus cells are seen, especially in a elderly female patients, you should think that this can be only a shedding of the normal epithelium there. This can be mistaken as pus cells in routine lab investigation. So if the patient is symptomatic or immunocompromised status, if there is large number of pus cells in the urine, then you have to consider the diagnosis of urinary tract infection. Whenever urinary tract infection you can get associated urine findings like proteinuria can be there, urine nitrate can be positive. Many gram-negative organism can reduce nitrate to nitrate. Then it is an indicator for bacteriuria. Urine pH, alkaline urine in patient with UTI suggests a presence of urea splitting organism like protease, some strains of Klebsiella, Pseudomonas provincia, like that. So pH also will give you some values or clues towards the diagnosis. But most important diagnostic feature will be pus cells. Now culture is very, very important. Colony count more than 10 to the power of 5 in one sample in a symptomatic individual. Colony count more than 10 to the power of 5 in 2 samples in a symptomatic individual will give you a diagnosis of urinary tract infection. Again, when you are discussing about the culture in urinary tract infection, there are few important things. Always, when we have already discussed that most of the organism which can produce urinary tract infection are gram-negative organism like E. coli, Klebsiella, Pseudomonas. Always look at the bottom of the culture report. You can see whether it's a ESBL positive or negative. ESBL means extended spectrum beta lactamase, and they can be resistant to most of the beta lactam antibiotic like penicillin, cephalosporin, and aztreonam. So remember, if ESBL is positive, there is no point in treating these patients with ceftriaxone or routine penicillin. You have to go for extended spectrum penicillins like piperacillin tazobactam or meropenem, like that. So we have to be very careful. And one more important thing is we have to follow up the cultures, previous cultures or next cultures, follow-up cultures, because if a patient who is coming with recurrent urinary tract infection with same organism in the all previous cultures, you have to remember that it is the treatment was incomplete, and this is the organism which is coming from inside. Whereas in a recurrent urinary tract infection, in culture reports you are seeing multiple organism. You can think that this is an external organism coming from outside, either from outside of the body or through the blood. It is coming through the blood route. So we have to follow up the previous cultures also. That is very important to know whether it's a same organism in all cultures or different organism in cultures. So ESBL means the best antibiotic will be carbapenem family. If the patient you are treating as an OP patient, ertapenem will be an ideal drug because it's 1 gram IV OD is the treatment. Whereas if the patient is getting admitted to the hospital, imipenem or meropenem will be ideal choice. If the patient is not affordable, you can go for quinolones or the drugs like piperacillin tazobactam if you are considering the cost. Now, culture negative UTI is very important. Like a patient who is having fungal infection, fungal UTI, culture will be negative. You have to go for fungal culture if you are suspecting a fungal UTI. Viral UTIs, most of the time culture will be negative. Now, sexually transmitted disease, many of the sexually transmitted diseases, culture will be negative. Tuberculosis, culture will be negative. But the most common cause for culture negative UTI is partially treated bacterial urinary tract infection. That means if you are getting a referral of urinary tract infection, if the patient is already started on antibiotics, then when we send urine for culture, most of the time they are negative or the colony count will be suboptimal. So we have to be very careful in interpreting this type of conditions. Now, these are the common causes. We have already discussed that culture negative urinary tract infection. You have to see this chart. I am not going to the details of culture negative urinary tract infection here. But the most important thing in our country, if there is a culture negative urinary tract infection, if there is no previous treatment given, rule out fungal infections in diabetic patients. Repeatedly, if you are getting urinary tract infection and not responding to your routine treatment, always rule out tuberculosis. That is very important in our country. So, genitourinary tuberculosis is very common in our country. The most important message from this presentation is when you are getting a culture negative urinary tract infection, repeated culture negative urinary tract infection, always investigate for tuberculosis. You can get bacterial culture, urine for bacterial culture, AFP routine can be done, and gene expert to diagnose tuberculosis also can be sent, especially if the patient is diabetic. Remember, if you don't treat tuberculosis, especially in renal tract tuberculosis, it can produce permanent damage to the genitourinary organs. Other investigations, like we can see WBC count, it may be elevated, CRP may be elevated, ESR may be elevated, blood culture can be positive in septicemia, procalcitonin will be elevated in bacterial urinary tract infection, and it will be highly elevated in bacterial urinary tract infection with sepsis. Renal function test, creatinine can be elevated. Serum sodium, most of the patients who is having urinary tract infection, you can see patient will be losing large amount of sodium through the renal route. They can have urinary tract infection with hyponatremia. So, sodium is a very important factor of altered behavior. Hyponatremia is a very important factor of altered behavior, especially in patients who is having urinary tract infection, mainly in elderly individual. Then USG should be done, CT abdomen should be done. You can pick up stones, malignancies, and prostatic enlargement. Prostatic enlargement, if you found prostatomegaly in a patient who is having urinary tract infection, always try to rule out post-voidal residual urine. So for that, initially bladder has to be full. Then do an ultrasound, see whether there is cystitis, what is the size of prostate, everything. Then ask the patient to void the urine. Then after voiding, you have to see the amount of urine which is remaining inside the bladder. That is very important, because any urine remaining in the bladder after micturition, especially in diabetic patient, that can be a good culture media for the bacteria, because that contains sugar, water, and bacteria can grow easily in that. So this type of patients, we have to advise after micturition, one more time they have to go for micturition after 3 minutes or 5 minutes, so that they can avoid the remaining amount of urine. That is very important in treatment of urinary tract infection. Urogram, urethrogram, cystoscopy, all these things are important when you are suspecting a structural deformity in the tract. Now, the treatment is very important in urinary tract infection. In simple terms, most of the urinary tract infection in adult we treat with quinolones like norfloxacin 400 mg BD, ciprofloxacin 500 mg BD, ofloxacin 200 mg BD or 400 mg OD. That is a common treatment we give in our clinical practice. But there are other drugs also can be tried. You have nitrofurantoin 100 mg BD can be given. It has got some gastritis. Then other things are quinolones. Bactrim DS, that is trimethoprim sulfamethoxone, can be given. Bactrim DS is one of the common brand name, or Septran DS. It can be given BD for 7 days. Fosfomycin is an old drug, but recently it has gained some importance in urinary tract infection treatment. Fosfomycin 3 gram as a single dose, that is very important. Fosfomycin 3 gram as a single dose in uncomplicated cystitis can be given. And depending on the severity of infection, you have to increase the duration of treatment. In pregnancy, we can give amoxicillin with clavulanic acid. Try to avoid fluoroquinolones, but it is not a contraindicated drug. But there are some adverse effects for fluoroquinolones, which is prescribed in textbooks. So many physicians avoid these fluoroquinolones in pregnancy. Cephalexin can be given, cefixime can be given. There is a safe drug, third generation oral cephalosporin, 200 mg BD can be given. But most doctors prefer to give amoxicillin clavulanic acid or ampicillin sulbactam combination in pregnancy. Complicated UTI, the main difference between complicated UTI treatment and uncomplicated treatment UTI, it is the duration of the treatment. Duration of the treatment in uncomplicated UTI is only for 5 to 7 days, whereas in complicated UTI it is always for 14 days, and sometimes it may extend for some more time. Many months we have to give, like we have to give UTI prophylaxis for many patients who is having a structural deformity. Now, complicated UTI, we already discussed that there is an element of structural deformity in complicated UTI and patient who is having immunocompromised status like diabetes. The problem with these type of patients is even if we treat with 1 or 2 weeks, the bacteria can present inside the urinary tract because there is a structural deformity. Bacteria can remain in the urinary tract for longer period. So it is better to treat the patient for minimum 14 days, and sometimes we have to give prophylaxis for the patient. Prophylaxis we'll discuss afterwards. That has to be given for many months. Now, supportive therapy, you can ask the patient to take a large amount of water. Only thing, if there is a hydronephrosis, we have to be very careful in volume expansion. Otherwise, patient can be asked to take a good amount of water. Alkalization of urine can be done if the patient is having severe dysuria, especially the urine pH is very low. Analgesics like urinary spasm relievers like flavoxate, that is Urispas, one brand name, and pyridium or phenazopyridine can be given 200 mg TID. That relieves the spasm of the urinary tract. Other antispasmodic like dicyclamine can be given. Sodium correction can be given in patient who is having hypernatremia. Dysfunctional voiding, many patients may require tamsulosin. Whether it is a male or female, we can give tamsulosin, that is recommended. Originally this drug is designed for BPH only, but urinary tract infection also we can give this drug. Chronic recurrent UTI, there is an antibiotic prophylaxis regime. You can give Bactrim DS once daily, nitrofurantoin 100 mg OD or norfloxacin 400 mg OD, cephalexin 250 mg OD, fosfomycin 3 gram every 7 to 10 days. Fosfomycin is a very costly drug, but it is the advantage of this drug is only once in a week can be given for prophylaxis, whereas most of the other drugs we have to give daily. But this can be given up to 6 months. If you are seeing any patient who is having recurrent urinary tract infection, put them on norfloxacin or Bactrim DS or cephalexin or fosfomycin in this dosage regime for 6 months. Most of the patients will have good control of urinary tract infection. But along with this, if the patient is diabetic, we have to control the diabetes. If the patient is having benign prostatic hypertrophy, we have to control that BPH growth. All these things are also important. Associated prostatitis, you have to always think about gonorrhea, chlamydia, enterobacteriaceae, pseudomonas, all these things. We have to start drugs for that also. So we have discussed about urinary tract infection, one of the most common infectious disease which can present to emergency room. Most of the time patient present with fever, chills, rigors, loin pain. Sometimes patient can develop severe sepsis, multi-organ dysfunction syndrome. Most of the patients who are mildly symptomatic may require only quinolones oral tablets like norfloxacin, ofloxacin, ciprofloxacin, or like drugs like ampicillin sulbactam or amoxicillin clavulanic acid, or we can give drugs like routine drugs like cefixime, that is third generation oral cephalosporin. Always take the history of sexually contracted diseases. That is very important because in sexually active male patients it can be mostly sexually transmitted disease. So we have to treat that also. If you are suspecting that, one of the most useful drug in that category will be doxycycline. Doxycycline will cover almost all types of organism, like it can cover gram positive, gram negative, anaerobes, atypicals, everything will be covered by doxycycline. It also covers the sexually transmitted organism also. So there is a very safe drug. Quinolones also have similar action. Azithromycin also has got similar action. So these drugs can be tried. If the patient is highly symptomatic, require admission, then you may have to give higher antibiotics like IV ampicillin sulbactam, piperacillin tazobactam, or meropenem. Like that, higher antibiotics we have to give. If the patient is having urine shows ESBL positive, we have to be very careful. If the patient is getting admitted, we can go for drugs like meropenem, imipenem, or piperacillin tazobactam. If the patient requires injection and he can go home, that OPD basis treatment, we can go for ertapenem, that's a carbapenem. Once daily dose is enough. If the patient is not affordable, we have to go for smaller drugs like quinolones. They also act against ESBLs, but not exactly like meropenem.